So we have a 21-year-old man here with focal epilepsy and cavernous malformations, which were resected when he was 14. He had been seizure-free for 3 years and then presented to an outside hospital with concern for status epilepticus and was intubated, sedated, and schlepped off to UAB where he got admitted. And that first admission was pretty short, about 5 days long in the neuro ICU. He did okay. He did have a complication of some upper extremity DVTs. Came back the next day after he got discharged, again, intubated and sedated from that outside hospital for concern of these generalized tonic-clonic seizures. Ended up back in our neuro ICU and had this really complicated course at the hospital. And this is not the main point of my case, so I'm going to kind of skip through some of this, but you can see here, the blue line, I'm trying to show where he was having electrographic seizure activity, and then the purple line is showing where family was having push button events that weren't corresponding to any seizure activity. So he had this prolonged stay because they put him in global suppression of his brain at one point, and then he developed ventilator-acquired pneumonia and went into ARDS, had to be proned. They were about to put in a PEG tube on him, and finally one of the neurologists said, like, let's stop aggressively treating some of this lack of burst suppression that we're seeing here. And then he was able to be extubated 2 days later, and probably just has some baseline cortical dysfunction there. But this was very traumatizing for this patient, obviously being in the ICU for this long, being very sick. He had to go to rehab afterwards because he had decompensated so much from this hospitalization. Now, were the original seizures organic or psychogenic? I don't really know, but I do find it strange that on both presentations, he had the ability to say, I don't feel well, drive to his mother's place of employment, and then start to have epileptic-like activity there. But I was not a part of this treatment team. This was just me going through everything. I was his therapist. So let's talk for a second about psychogenic non-epileptic seizures. So this is the most common functional neurological disorder. And functional neurological disorders are actually the second most diagnosed disorder in an outpatient neurology clinic next to migraine. Okay, so I think sometimes people think, oh, this is rare. It's not that rare. Lots of people have this. So we think it's caused by classical conditioning, but then there's also this integrative cognitive model where we think that people have this automatic execution of a learned idea of a seizure due to some either internal or external stimuli. And really complicating things is that 40% of people with epilepsy actually have psychogenic non-epileptic seizures. So that kind of goes with this integrative cognitive model. If you know what it's like, you could very easily act that out, right? So misdiagnosis and lack of access to care can delay treatment and diagnosis for up to 7 years. And in the ER, about 1 in 4 patients who comes in with psychogenic episodes actually gets intubated and goes to the ICU. It's wild. So going to the ICU, as you know, it's very distressing, especially for this patient. He was there for a month. So we need to be able to identify this. So there's a specific kind of therapy called retraining and control therapy. This was developed by Dr. Fobian at UAB. It's a manualized intervention that uses habit reversal principles to interrupt these kind of automatic episodes. And she's been very successful with the pediatric population using this specific type of therapy. She was able to show that 82% of the kids that she was seeing were without psychogenic episodes at their 60-day follow-up. And this can work in as few as 5 sessions. So it works very quickly. I love behavioral therapy. I'm not such a huge fan of the supportive therapy. It takes too long. So this can work really quickly and have a big impact on people's lives for something that's quite debilitating. All right, so that was all. His last course in the hospital was in January. He goes back home. He's still kind of having these episodes, and I think the outpatient provider is getting pretty suspect that there's a functional disorder going on here. So he starts to have, again, these generalized tonic-clonic episodes, and the outside provider is like, don't go to that outside hospital where you'll likely get intubated and sedated. Just go straight to UAB. And so he comes back in. He's not in any post-ictal state. EEG is without seizures, and he's still having these like bilateral shaking, and the legs are going, and he's grunting, and the attending physician throws water on him, and he flinches, and they call it PNES. And 4 days later, he's in my psychotherapy clinic. So I'm going to kind of go through here what we do in each session. So in my first session, I take an intake about what's been going on. And I really try to figure out, because this patient has epilepsy, what does the epilepsy look like? What do we know from 4 years ago versus what is this looking like now? And let's try to find those differences, which is very important for family to be able to distinguish like what's organic and what's not. And then we create I provide a lot of psychoeducation. One of the things I talk about in there is that it's not necessarily a stress response. So in a lot of children with functional neurological disorders, there's no psychiatric comorbidity. In adults there is, but he's kind of in the transitional age here. He was 21. So, but we talk about how, like, if you ate lunch today and you had shrimp and then you vomited 30 minutes later, the next time you smell shrimp, you're probably gonna think, oh, that's what made me sick, but it could have been something that you ate the day before. And that's kind of a way to explain like why these episodes are happening. And we create a behavioral plan. And this is the most important thing. And it doesn't take that long, which is what I really want to stress to us today. So we talk about breathing, which we all learned this morning, right? We did that already with our speaker. And then we talk about calm thoughts. And this is not, I'm sitting on a beach somewhere and it's all lovely. No, we're going to say, I know what this is. This won't hurt me because I know what this is. And this was a little hard with him because that hospitalization was rough. But we know in psychogenic and functional disorders, it doesn't hurt them, right? They have an episode and they guide themselves to the ground. They don't smack their head on the ground, right? They don't bite their tongue. They don't pee on themselves, right? So we talk about how we kind of know what this is and that you're going to be okay. And then the control thoughts we talk about are, I can control this. I don't have to have an episode. This is the one that I stress to people the most. I'm safe and I have a plan because we're making a plan together for this. And then the next part of this is doing retraining of symptoms where you do an opposing response. So if their arm is going to go like this, no, we're going to very calmly pump our arm. Okay, if we're going to lock up, we're going to pump our feet. Okay, we're going to do something that is the opposite of that. I think the weirdest symptom I had is somebody felt like a hood was going over their head. So we just had her very easily kind of like scratch the back of her head a little bit to try to get rid of that sensation. And if they shut their eyes, you need to keep, the eyes need to stay open and you need to do other grounding things where you're like, okay, that is a chair, that is a light, okay? And so we talk through this and then I say, you're gonna print this out. It's gonna go on the mirror in the bathroom. It's gonna go at the table. It's gonna go in your car. You're gonna take a picture of it and it's gonna be your screensaver on the phone. And you're gonna practice this 10 times a day because we want this to be automatic and not what you're doing. And so that first session is pretty robust because we do all of this together. So I did this with him on the first day and family joins for this because they're a big part of it. And that's important here because mom was kind of reinforcing some of the behavior. So next time I saw him a week later, he's still having multiple episodes. And mom's taking him to the fire station, taking him to the hospital, which just reinforces the behavior. So this session, we spent a lot of time saying, once you know he's safe, I need you to walk away from him. Don't speak to him and don't pay it any more attention because the more attention you pay it, the more you're reinforcing the behavior. And then provide a lot of support. You can do this, you got this, and guess what? No episodes by the next week. And he even had to go to the hospital for a brown recluse bite and he didn't have any episodes there because being in front of providers started to create a lot of anxiety where he might have gone into an episode. Next, he's still not having any. We talk about some CBT principles, some thinking traps. We do a thought record together. He's still doing good, still doing good. And I was like, all right, we're going to be done. Okay, he had spontaneous recovery. He actually, a tractor rolled over onto him, which is scary. And he said he was able to do some of the control thoughts. And then somebody said they were going to take him to that outside hospital where he was intubated and sedated. And he ended up having an episode. But this is okay. It's expected. And so we talked about this, where you have symptom onset, we start treatment, your symptoms go down, and you could have this little extinction burst, okay, where you're going to have one. But that's okay. It doesn't mean you failed. You're good. It's fine. And we talk about how after that, there's usually symptom extinction. And so this is one of the diagrams that I use in that. He had 0 episodes after that, and I was just very supportive. He went to the hospital, kidney stones, still 0 episodes. And then he had a friend die, and he had some minor ones. They weren't as severe as they were before, and so we just reinforced the plan. And then this was kind of weird at the beginning of November, where he demanded to be taken to the ER. But this is why it was so important to work with family here, because mom said no, and she didn't do it. And a month later, he was again all symptom-free, went back to work. And I've checked, he's not been back to the hospital since. So I think we were successful, hopefully. Okay. So at that last session too, we talk about how you could have symptom remission there in that green box, but that's okay. What you're going to do, that plan that we made, you're just going to go back to the plan and you're going to keep practicing it a little bit more. So ReACT can be up to 8 visits, but I think, some of these things are not that hard. Like, look, we just talked about it in a very short amount of time here. And so I think it's good that we can all provide psychoeducation to patients on this, right? You're not alone. This is common. We know what this is. Okay, you're not a unicorn. I think kind of getting away, I think in times we try to say like this is an anxiety response or a stress response. I think if we could move more towards like the conditioning response, that might be a little bit easier than saying like, oh, you're just anxious and this is why this is happening. And you, I think pretty easily can talk about calm and control thoughts with people or try to say you can do some opposing responses if you had time for that. But I even do this with patients that I see in my psych clinic just in follow-up. I've got a few who have TBI and also have psychogenic episodes. And we talk about this sometimes as I reinforce what the therapist is doing, even though I'm not their therapist. And so you can check in at return visits with people. Hey, how's it going? Like, are you able to kind of control your thoughts? Are you calm? Because again, it's hard for people to get into therapy. Our wait times are very, very long. And I would say avoid disability paperwork. I saw 8 patients last year for ReACT therapy. And the one that asked me every time for disability paperwork did not get better. The other 7 got better pretty quickly. And I think it's good to let them know this is not disabling. You can control this. And this is how you need to work on your plan. And so that's really all I got for you. Are there any questions? Mm-hmm. Sorry, I can't hear. I'm like that.
Any pharmacotherapy in conjunction with the ReACT?
Yeah,
at the same time?
he did. It wasn't much. I think he was on a 25 milligrams of Zoloft by his primary care provider, which I think is more placebo than probably helping him. He was quite resistant to therapy actually, and like mom was like, can we make this like the best experience we can for him? And I was like, I'll do my best, like I can't say how he's gonna act here, but I really think that he needs to go now and work on maybe some of the anxiety and PTSD that he has from like in more of a trauma-based therapy from that ICU admission, which was not me. I like behavioral therapy. It works quickly. I kind of recommended that. Will they go and do that? I don't know. But I did try to put him in contact with our therapists who do that. That's kind of a next step. Mm-hmm.
Hey, Chelsea. So I've seen this PNES primarily in kids.
Mm-hmm.
So kind of a 2-part question is, what's your lower age limit for ReACT therapy? And then how do you get buy-in from families who are having serial admissions,
Yeah.
that are very demanding that something's wrong?
Yeah. And so I don't know how young she's gone on this, but with children as well, the ReACT therapy involves schools too. Like schools can't keep sending the kids in the ambulance to the hospital. And there is like a whole kind of community session. So there's extra sessions in there where they do things like that to try to get that buy-in. But family, it's hard. I mean, family sometimes thinks their kid's dying. And I mean, even this mom was like, well, he was just hospitalized for a month. And I'm kind of like, yeah, and he had MRSA and, but what really brought him there? So it is kind of hard to get that buy-in, but I think once you can get that buy-in, that's very, very important. And I think you see a lot of change there. So you really have to build that full community around, hey, we know what this is and we don't need to overreact. Actually, I need you to walk away. So.
How often do you encounter resistance when people say my seizures are not psychogenic when in actuality they are?
Well, I mean, everyone who's coming to me was coming for a therapy knowing that it was psychogenic. And I think that might be a better question for a neurologist because they see it a lot more than I do. But again, this patient also had epilepsy and reason for epilepsy. So it is hard sometimes to convince that, but that's why it's so important in that first session to be like, okay, what were your symptoms when you weren't having all these episodes? And let's find those differences there. And then they kind of say, okay, yeah, you're right. And then they don't have a post-ictal state, right? So you feel different after this too, and really getting into that kind of mind-body connection with them.
And have you applied the ReACT therapy to other similar conditions, especially with kids who have similar episodes?
Yeah, I mean, I think with any behavioral thing, I mean, I guess I would still say it's, you know, kind of functional, even like kids who have like the chronic tummy aches and things like that too. I suppose you could. It's the same kind of idea of creating some calmness around that. I don't know how you would do kind of an opposing response, because this is specifically for functional disorders. But I think behavioral therapy in general, you know, we do some things with behavioral therapy for like ADHD as well. So.
All right. Well, thank you very much.
Thank you.
Wonderful presentation.